Welcome to AETCM, the emergency medicine channel.
Yes,
Present in the case of a 25-year-old male who came to ER with complaints of fever with rigor, along with an epigastric pain and 3 episodes of vomiting since the last 6 hours. And on initial 10-second assessment, the patient was conscious, was oriented, and airway, it was patent. There was no pooling of secretions. There was no stridor. Breathing, the air entry was bilaterally equal with a respiratory rate of 21 beats, 21 per minute, and a saturation of 97% in room air. And there was no presence of any added sounds on auscultation. The circulation, the patient had a blood pressure of 60/40 millimeters of mercury, with a pulse rate of 72 beats per minute and a capillary refill time of 2 seconds. So that time
tell something about capillary refill time.
Capillary refill time is usually measured to know about the permeable, the perfusion on along the body. So it's mainly in the case of shock, there will be increased. The refill time will increase. Increase. It will increase. So there will be an increased capillary refill time.
Capillary refill time is delayed.
Yeah.
You should not tell increase. It is delayed. Yes. That is the apt term.
Yes. So usually it's within 3 seconds. So if it's more than 3 seconds,
the circulation is good. The return of circulation is fast.
Yes.
Otherwise, it is delayed.
Yes. So he had a capillary refill time of 2 seconds, but patient had a BP of 60/40. So initially we.
So what do you think? Patient is having 60/40 BP. Yes. Capillary refill time is less than 2, and heart rate is
72.
So what do you think? What are the possibilities?
The patient is in physiological prevention.
It's a normal BP for that person. Maybe his BP may be 80/60. Mild reduction can happen. Suppose it is a significant BP reduction, first we should get a tachycardia. That can be masked by beta blockers or some other drugs, drug abuse, all this. But capillary refill time is not like that. It cannot be masked. If there is a delay, that means it is hypotension. Here it is not there. So no need to worry about the BP.
Yes. But in this patient, as a precaution, we initially also inserted 2 large bore IV cannulas. We also checked the volume status at that time. IVC was non-collapsing.
That means he is not having dehydration.
And then we checked the disability. Disability GCS was E4V5M6 with pupils 2 mm bilaterally equal and reactive to right, and GRBS of 122. And exposure, the temperature was 98.5 degree Fahrenheit, and there was no presence of any external injuries or rashes. And the patient but looked lethargic, looked tired. And so after that, we inserted 2 large IV bore cannulas, and also we gave fluids, looking the IVC status.
IVC is normal.
Yeah, IVC is normal, but patient had a 60/40 BP. So initially,
so what? Yeah. So this fear should go. Yeah. Unnecessarily, we should not give fluid. Even fluid is a medicine. Unnecessarily, we should not treat the patient because 80/60, 60/40, all you see various patients. You see all these BPs. You have to see whether the patient is physiologically preserved or not. So here pulse rate is normal. Your capillary refill time is normal. What happens to his lactate level?
Yeah, lactate level is 1.2.
1.2. That is also normal. Do you think that this patient is really having hypotension? Yes or no?
No.
It is no. It is a big no.
Okay.
Because we don't have any evidence for hypoperfusion in this patient. Maybe he is having some dehydration. That doesn't mean that intravascular dehydration has occurred. Okay, you can give fluid, but no need to rush the fluid, no need to give noradrenaline, nothing. Okay, so you need to give fluids. That's okay. That is accepted. But unnecessarily treating this patient with lot of fluids, noradrenaline may not be correct. Yes. Because you have evidence that there is no internal collapse of circulation.
Yes. Okay. Following which we took as adjuncts to the primary survey. We took an ECG showing a normal sinus rhythm was shown, and we took a CBC-CRP point of care also was taken.
That what will you see for dehydration? CBC.
In hematocrit.
What was hematocrit?
Hematocrit was 42.
That also doesn't show that this patient has lost significant volume from the intravascular compartment.
Yes. So patient had a total counts of 7,800 with a hemoglobin of 14, with a platelet count of 1,84,000 and a CRP of 15.2. And we also took a VBG, venous blood gas, showing no evidence of any acidosis or alkalosis. Glucose was 125, potassium of 3.6, sodium of 136, and creat was 1.05.
What will happen to sodium in dehydration?
It will increases. And lactate was 1.2 and anion gap was 8. So initially
What is the importance of anion gap here? Is the patient is having
no patient
acidosis?
but this patient had an
What is
epigastric.
importance? You are telling something. I am only asking why
Yeah.
did you tell that? When did you calculate the anion gap? Anion gap should be calculated in acidosis.
Acidosis, yes.
Otherwise, there is no
significant.
point in calculating all these things and wasting our time.
Yes. And following which we also did a focus lung ultrasound at that time, showing no V lines. Lung sliding was also normal. There was no presence of any pleural effusion. Echo was also showing good LV and no RWM was present. Then we took the sample history. Sample history, the patient, 25-year-old male. He had no non-comorbs. He presented to ER with complaints of fever, which was low grade and intermittent in nature, along with rigor. And the patient also had an epigastric pain since last 6 hours, along with 3 episodes.
So for what will you suspect? Suppose the patient is having hypotension. According to hypotension, is the heart rate is normal. There is no lactate elevation. There is no, what else is there? Sodium is not normal. Everything is normal. Patient is having rigor. What else you suspect other than volume loss from the body? Patient is having rigor. Fever is there. What might have happened inside to create some amount of hypotension?
Inflammatory.
Vasodilatation. This is very simple.
Vasodilatation.
Normal process, vasodilatation. Heart rate might be obliterated by something else. We don't know. Simple vasodilatation can produce all these things without having the compromise in your internal circulation.
Yes.
Okay, so that you should keep in mind. That's all.
Yeah. And following which, and along with it, this patient also had 3 episodes of vomiting the last 6 hours. The vomitus, it was non-projectile, it contained food particles, it was non-bilious and non-blood stained. And the patient did not have any history of loose stools or constipation, no history of any chest. Patient had history of occasional chest pain at intervals, but the chest pain was not radiating to neck or shoulder or to the back or to the abdomen. And the chest pain lasted for around 30 seconds to 1 minute, and it was not induced by exertion. And also patient did not have any history of any palpitation or sweating, orthopnea or PND, and the patient did not have any history of any dysuria or any blood in stools or urine, no history of any body ache, backache or headache. Patient did not have, and the patient did not give any complaints of any weakness of limbs also. And the allergic history, he did not have any allergic history. He is not on any regular medications. Past history, he gives a history of regular alcohol intake since he's taking it since last 3-4 years.
Alcohol produce all these things.
Yeah, it could be a possibility. Could be a alcohol gastritis.
It also can produce all these things. Mild hypotension because of vasodilatation. Okay, if it is in limits, then it produces only minimal vasodilatation. Yes. And if it is more than that, it produces tachycardia, altered behavior, ataxia, all these things.
So this patient did not give any history of binge drinking as such, but patient had a history of regular alcohol intake. So last intake was taken yesterday, and the last meal was taken 6 hours back. Following the giving a history of an epigastric pain, along with having a history of regular alcohol intake. We moved on to the examination, the physical examination. The patient on examination was conscious oriented. Chest was clear. CVS examination, S1, S2 was normal. There was no presence of any murmur, and per abdomen there was mild epigastric tenderness. Along with that, the bowel sounds were heard. Abdomen was not distended. And then we, following there was a mild epigastric tenderness, we moved on to USG abdomen. and the USG abdomen was taken mainly to rule out the possibility of pancreatitis is there or not. But there was no presence of any pancreatic head inflammation. It was not present, and but it showed the presence of a dilated or inflamed bowel loops was present in that. So they advised a CT correlation to rule out any obstruction is there or not. And following which we had also did the lab tests. Lab tests we had done the amylase lipase. Amylase was 46, lipase was 343. Bit on the higher side.
So which one is more specific?
Lipase is more
The
specific.
fold elevation of a lipase indicates some amount of pancreatitis.
Yes.
Okay. Minimal pancreatitis is there.
Yes.
Okay.
And this patient we also did following the history of intermediate chest pain, we also did a cardiac enzymes. Cardiac enzymes turned to be chest turned to be positive. Yeah, it was 0.7940 initially, and CKMB was
In alcohol elevate chest optic. It will not elevate.
It will not
Produces vasodilatation.
elevate.
Normally it will not produce.
Yes.
Okay. Chronic alcoholism you can get this one coronary artery disease.
Yes.
Not acute.
Yes.
There are drug abuses which can do all these things. Drugs which
Yes.
can produce all these
All
things.
these things. So then we had also done a CKMB. The CKMB was 14.95. It was also then the total CK was 990. By the ratio wise, there was cardiac involvement was low, but the patient had a history of fever. Enzymes were mainly elevated, so we had a doubt of a myocarditis also. But ECG does not show any features of myocarditis. We took a cardiology
Do you
opinion.
see picture of myocarditis?
Yeah, there will be a PR depression.
PR and depression.
Depression.
What is the common kind?
Global tachycardia.
Tachycardia is the most common. Some ST segment depression,
Yeah.
like you told, PR segment
Depression
depression.
and also
But most common is tachycardia.
tachycardia. And it was ruled out from the cardiology side. And then we had admitted into the IC was admitted. The other tests was urea was also normal. It was 48.9, and the bilirubin was 1.23, direct bilirubin of 0.42, and then following which the other blood tests were normal, and but patient's BP was already on the lower side. We had done a serum cortisol too, 8 a.m. morning cortisol showing 8.87.
It was random, no?
Yeah.
Random. We sent random.
Random, yeah.
I think random was sent.
Yeah.
That was low.
Yeah,
8 a.m.
8 a.m. cortisol.
Okay.
So it was in the lower side considering his BP.
Okay.
So then, then we had, he is already giving a history of an alcohol intake. So we just sent the toxicology screening samples to. In the toxicology screening samples, it came to be positive for cannabis.
Okay.
Tetrahydrocannabinol, THC was positive for this patient.
Is it significant amount or just positive? Just positive, it's a qualitative test.
Yeah.
Is there mention about the quantity? Ah. Okay.
So that's the final report is actually pending. So that's this patient.
So what are the clinical features of cannabis toxicity and withdrawal? How do you manage it?
Yeah,
Both.
so toxicity mainly in case of cannabis is mainly it produces depression symptoms. So basically it produces impaired attention, concentration. There can be a loss of short-term memory and functioning. Patient will be having increasing fatigability. So increase will be fatigue, and also patient will have nausea. Along with patient can have a postural hypotension. So that is mainly depressive functions will be present. If in case of withdrawal, it will be the
So in that case, you don't get tachycardia. You get
yes,
bradycardia with
hypotension is what is the feature which is developed. In case of withdrawal, it's just the opposite. So patient will be very much anxious. And increased tachycardia and hypertension can present as cannabis withdrawal symptoms. So these are usually what occurs. So cannabis is usually one of the most cultivated illicit drug which is used, and also the site of action is used in the cannabinoid receptor. Cannabinoid receptor is usually it's a G protein coupled receptor which is usually there is CB1 receptor and CB2 receptor. CB1 is usually in the CNS, so it affects the basal ganglia, hippocampus, and also the cerebral cortex. So its mainly function is to inhibit the release of acetylcholine and also glutamate. So it's having an inhibitory function, and also dopamine it inhibits and serotonin. And also CB2 the receptor, it acts on the peripheral systems, so mainly in the splenic hemorrhage, splenic that macrophages, and also in the B lymphocytes. So it also in the nerve terminals, it's having a peripheral action. And there is actually two endogenous cannabinoid agents like anandamide. Anandamide is an endogenous cannabinoid agent. So there are different routes of administering how cannabinoids are used. One will be the inhalation route. Inhalation route is which is rapidly absorbed within a time of 15 to 30 minutes, and its effect lasts for about 4 hours. And then other is ingestion route. Ingestion route is delayed. Usually absorption is delayed because of high first pass metabolism. Within 30 minutes to 3 hours is what is the time of absorption. And there will be increased degradation of this by the gastric acid too. And cannabis is known by many names. It's known by name of pot, grass, dope, Mary Jane, hooch, bead, and hash, and ganja. So these are different types of cannabis forms which are present. And toxic effects, there is no clear demarcation between the dose and the toxicity effect. So the inhalation, usually if it's by 2 to 3 milligrams of tetrahydrocannabinoid, can produce the symptoms of mainly impaired attention, concentration, and also short-term memory deficits, and also executive functioning. Proper functioning can also be, executive functions can be lost. And at a dose more than 7.5 milligram, the patient can present of postural hypotension, panic attacks, and even delirium can also be present, and presence of myoclonic jerks can also be present. Other effects are mainly the presence of diffuse fatigue with vomiting and lethargy, and diarrhea can be present, or can alternate with constipation also. Signs mainly include bradycardia along with hypotension, and the increased respiratory rate. And as sign, we can get a conjunctival congestion can be present, red eyes can be present, dry mouth, and increased appetite can also be present. Patient can develop slurring of speech due to the lethargy. So these are the clinical features, but what we always fear is the complications associated with the index. If patient is a known case of asthmatic, he can get an acute exacerbation, and even can get into a pneumothorax. Spontaneous pneumothorax can also occur in such patients following the intake. So we must always, if patient is having a chest pain with giving a history of cannabis intake, we must look for any presence of pneumothorax is there or not. And also patient can develop dangerous complication of myocardial infarction. So this patient had an elevated cardiac enzymes, like TROP2 was elevated. So that's why we had that fear too, but we just ruled out that also too.
What is the role of beta blockers in this type of myocardial infarction? You get amphetamine-induced, cannabis-induced myocardial infarction. Are beta blockers are safe or not? You have to read about that. Beta blockers are not very safe. They say it should be avoided. You can read about that.
Yes. And so along with that, patient is also having a possibility of getting a cerebrovascular accident. So you must always rule out if patient is having any slurring
Stroke,
of
myocardial infarction, everything is common.
Common.
Pneumothorax.
Yes. Diagnosis we can do by urine screening, but that is not always specific for the compound. There can be false positives too. If patient is using an NSAID or a proton pump inhibitor like pantoprazole, we can get a false
Positivity can come, but quantitative analysis
will be picked up. And so these are the with various features, and different DEDs, like patient will be coming with fatiguability, so fatigue. So that time we should rule out any hypoglycemia there in this patient, or any hypotension, meningitis, hyponatremia should be like in old age patients, or even so in such patients we must mainly rule out. In case of opioid can also present with similar features. So in such situations, administration of naloxone will improve the symptoms of opioid. So overdose. So that is how we differentiate.
Naloxone in a opioid overdose patient. What will happen? Naloxone is very good drug which can reverse the toxicity of opioid. But what will happen after this?
Withdrawal.
Withdrawal symptom is one. Second is what?
Short act.
Short acting means again they will have symptoms. If the patient is chronically on this type of drugs, suddenly you withdraw or you stop the effect of the drug, patient can have other problems like you can have seizures, you can have altered behavior. Okay, everything will aggravate suddenly. You have to be very careful when you are using. Only if the patient is in coma, to know whether it is due to that drug or not, he can try it. But treatments are not recommended. That will produce more adverse effects. Okay.
So the treatment wise, mainly it's maintaining the airway, breathing and circulation. If patient is coming in a comatose state, we must always look for to maintain the airway. And patients, there is a propensity for seizure potential. So we must always, if there is presence of seizure, use benzodiazepines. And there can be also then all the symptomatic management according to the complications. If patient is having a myocardial infarction, we must treat accordingly, or stroke, or treat or pneumothorax, means treat accordingly is what's the usual guideline. If activated charcoal during overdose is found to be less effective. And then about synthetic cannabinoids are also present. This is what is actually the cannabis sativa plant. Like synthetic cannabinoids are usually different compounds called as naphthyl indoles or naphthyl pyrols and naphthyl methyl indanes. So usually they have more severe symptoms compared to natural cannabis. So that's it contains increased agitation, and patient can be comatose also. It can two extremes, or patient can develop seizure, hallucinations and psychosis. Along with patient will have severe bradycardia, and also patient can have rhabdomyolysis. So that's a possibility, and hyperpyrexia along with increased rigor. So that's also a possibility in case of usage of synthetic cannabinoids, but that cannot be detected by urine screening or routine screenings also. So that is it.
Okay. Anything else? Okay. A patient discharged.